The treatment of advanced stage Hodgkin lymphoma has varied quite a bit over the years, depending on where a patient is in the world and whether a patient is younger or older. And so the standard has been to use combination chemotherapy for these patients, but in pediatric patients, at least in the United States, a majority of patients also received consolidative radiation. And that's important because this disease typically affects young patients who are particularly vulnerable to the late toxic effects of the chemotherapy and the radiation that we use to cure the disease. So recently, brentuximab vedotin, which is an antibody drug conjugate directed against CD30, became approved for the initial treatment of advanced stage Hodgkin lymphoma based on trials both in adults and pediatric patients that demonstrated an improvement in outcomes compared to the old combination chemotherapy standards. However, brentuximab vedotin, while it improved outcomes, there are still many patients who are not cured by their initial therapy. When it was combined with AVD chemotherapy in adults, there was increased toxicity compared to ABVD. And we still use different chemotherapy backbones between adult and pediatric patients, and a majority of pediatric patients, unfortunately, still receive radiation therapy. So there was a lot of room to improve on the treatment of advanced stage Hodgkin lymphoma. Now, we understood this opportunity to change the treatment paradigm with PD-1 blockade. Turns out that Hodgkin lymphoma has genetic changes in the chromosomes for the PD-1 ligands in the genes that lead to PD-1 overexpression on Hodgkin lymphoma tumor cells. And nivolumab and similar PD-1 blocking antibodies are effective treatment for Hodgkin lymphoma, both very treatment-resistant patients, that are later after many lines of therapy. But in fact, we've been using these drugs earlier and earlier in the course of therapy. And there was a study right around when we designed this S1826 study that showed that nivolumab combined with AVD was well-tolerated, safe therapy and effective for the treatment of advanced stage Hodgkin lymphoma. So that was the rationale, basically. We wanted to introduce PD-1 blockade into the frontline treatment of Hodgkin lymphoma, patients with advanced stage disease, and compare it to a standard at the time, which was brentuximab vedotin combined with AVD. Patients were randomized in a 1-to-1 fashion. We enrolled nearly 1,000 patients with a stage 3 or 4 Hodgkin lymphoma. And patients were stratified by age and clinical risk score. The primary endpoint was progression-free survival, and we enrolled a representative study, actually. 1/4 of the patients were under the age of 18, 10% of the patients were over 60, 25% of the patients were Black or Hispanic. And we had quite a number of higher risk clinical high-risk patients. So it was a very representative study overall. And I think that really speaks to the power of the way that we did this study, which was in our cooperative groups in the United States that include academic and community centers. And it was a collaboration between, led by SWOG, which I was the lead investigator of the trial through SWOG, but also with Children's Oncology Group, the pediatric, cancer doctors, and really a tremendous, amount of work went into building this collaboration and trying to harmonize the treatment, use the same chemotherapy backbone, and really try to get all these different treatments and see if we could narrow it down to just one. Remarkably, at the second interim analysis for the study, we saw that the primary progression-free survival endpoint crossed the protocol-specified statistical boundary, showing that nivolumab AVD was superior to brentuximab vedotin AVD in terms of progression-free survival. The hazard ratio was 0.48, so a 52% reduction in the risk of disease progression or death, with nivolumab AVD compared to brentuximab, which was really a dramatic result. When you looked at different subgroups, actually, the benefit of nivolumab AVD was consistent across the subgroups. So regardless of age, stage, clinical risk score, B symptoms, it was really remarkable to see this kind of consistent result. Nivolumab AVD was well tolerated. We did not see an increase, a high rate of immune-related toxicity. In fact, there was similar rates of immune-related toxicity across the arms. There was more neuropathy in the brentuximab arm. There were more liver function test abnormalities in the brentuximab arm. 22% of patients in the brentuximab vedotin arm discontinued BV as compared to just 11% on the nivolumab arm. So really, all in all, it was much better tolerated therapy. And there was more neutropenia in the nivolumab arm, but in fact, GCSF was not required in the nivolumab arm, whereas it was required in the brentuximab arm, which is one of the limitations of that regimen. And so that was an expected finding. There was no increase in infectious complications, even though the neutrophils were lower. And so that was important as well. So perhaps one of the most exciting results from the study was that across the study, only 6 out of 1,000 patients received radiotherapy. So that's a dramatic reduction in the proportion of patients receiving radiation, particularly the pediatric patients, compared to the old standard. And so the study, all in all, showed that nivolumab AVD improved progression-free survival, so it improved disease outcomes. It was well tolerated, better tolerated than brentuximab vedotin AVD. More or less eliminated the use of radiation, especially for the youngest, most vulnerable patients, and that we anticipate may reduce late toxic effects from the therapy, and ultimately has sparked ongoing collaboration in North America between the cooperative groups, including the adult and pediatric cooperative groups, to design future studies for Hodgkin lymphoma and other lymphomas that affect young patients.